Let me introduce Gauden. He is the director of Non-Communicable Disease and Promoting Health through the Life course at WHO Regional Office for Europe. He is a public health physician who has worked for WHO since 1998. He has held posts as regional advisor on non-communicable disease in the Western Pacific region and as a coordinator of health promotion in WHO headquarters in Geneva. And he has been director of a division of non-communicable NCD and health promotion at WHO Europe since January 2011. He has a special interest in health promotion, social determinants of non-communicable disease, and in the link between these diseases and the development agenda. And I'm asked him to talk about non-communicable disease and global health in the era of big data. So please go then, give us a talk. And
Professor Yoshizawa, Professor Fujiwara, colleagues, ladies and gentlemen, konbawa, hajime mashite, watashi wa Gauden Galea desu. That's the limit of my I am honored and grateful to be at this, not just this lecture, but this excellent day, which has been really memorable, as we have spent a whole day in discussing with young people, with PhD students, attending a seminar in collaboration, commemoration of the opening of the Masters in Public Health. And if the subjects that I have heard in the PhDs supervised by Professor Fujiwara and Professor Nakamura, themes of childhood, social determinants, life course, non-communicable diseases, and development. I was really impressed by the quality, the content, but also the topicality of the themes as we discuss all the preparations that are coming up in relation to the Sustainable Development Goals and the United Nations high-level meetings next year on tuberculosis and on non-communicable diseases. And of course, at the opening, I cannot but mention that today is, of course, World AIDS Day, another major challenge that we all need to be aware of in the field of development now and into the future. As it becomes a chronic disease, it has much in common with the way we manage non-communicable diseases. But today I will present not so much a lecture on work we are doing or mandates that we have received, but rather to try and allow myself some space and to go forward and explore with you the possible disruptions that we might face in the field of public health and global health as we are confronted with this concept that has become a bit of a fashion now to talk about big data. But I introduce first the concept of leapfrogging. I think you will all recognize leapfrogging from the picture, a game that mostly children play as they jump over each other. But I would like to introduce leapfrogging as a concept that might be interesting in the era of public health, as we consider public health today. I will explain it later, but I will just leave it here and ask the question, do countries always have to follow the same pattern of development in public health as other countries have done in the past? Can we not find some way in which we can step over or jump over whole steps that other countries may have been lost in for years, or even decades? As we look at the Sustainable Development Goals that has us by 2030 needing, for example, to achieve a 1/3 reduction in non-communicable disease premature mortality as compared with 2010, we are faced with a huge challenge in terms of time. In effect, we have 10 years to reduce by 1/3 the mortality rate in non-communicable diseases. 2030 sounds like a long time in the future because there's 2020 in between. It feels like it's almost like 2 decades. But in reality, we are effectively in 2018. In 2029, we need to write the report that will go to the UN General Assembly in 2030. So the challenge is, what can countries do between 2018 and 2028 in order to achieve in 10 years a groundbreaking set of qualitative improvements in public health and development around the world. And this is what the Masters in Public Health graduates are going to be faced with as a challenge, and your PhD graduates. How can we accelerate processes? What can we learn that we don't, mistakes can we learn that we don't need to repeat? And I will make a case for this based on my experience in Europe. Although it says global health, but my examples are largely from another region from Europe as a fodder for your own thinking. In 2013, we agreed on 9 targets. Globally, the World Health Assembly has agreed that we will achieve improvements represented by those 9 icons: in premature mortality, in alcohol, in physical activity, in salt, in tobacco, in blood pressure control, in overweight and obesity, in the control of cardiovascular risk, and in access to essential medicines and technology. So this year, we consulted the 53 member states of the European region, and we asked them, are you doing this? Are you doing that? We gave them a questionnaire that is standardized in WHO, the country capacity survey. And this, in one slide, is the summary of our results. As you can see, we are not doing very well. Indeed, in Europe, we're doing much better than many other regions, but at the same time, it's far from being good. It's likely that Europe will achieve its targets in the area of premature mortality reduction and in the area of blood pressure control. But we are declining so slowly in tobacco control and in alcohol control, and our overweight and obesity problem is rising so fast that it has the declines are too slow and the rise is too fast for us to be able to reach the targets in tobacco, alcohol, and obesity. And the other targets, either because we don't have enough data or because we don't have enough action, are all deemed to be endangered. So there's a high probability that we will miss many of the targets. We need to accelerate. But it's not just because we need to meet the agreements inside WHO. We need to accelerate because of this. I call this my spaghetti graph. So don't worry. If you can't see any pattern there, we will get a pattern out of it. But this is the spaghetti graph of the mortality trends in all the 53 member states of Europe from circulatory conditions. So if you took the 53 countries and you dropped them all on a graph, this is what it would look like, going back to 1970. So let's try and dig, like that person on the front slide, let's try and dig inside the data. And by the way, I don't pretend that this is big data. This is very small data. We will come to big data in a moment. But let's dig even inside the small data and see what patterns we can come. First, let's color them by 3 colors. Red are the countries that used to be part of the Soviet Union. So they are the Commonwealth of Independent States. Blue are the countries that were the old members, the first members of the European Union. These were the first 15 countries who joined the European Union. This is largely UK, France, Germany, the original members, basically, and the rich countries of Western Europe, or a good selection of the rich countries of Western Europe. And in green are those countries that joined the European Union after 2004. So already, just by looking at the colors, you can see that there are not one Europe, but 3 Europes. High mortality Europe, middle mortality Europe, low mortality Europe. Let's summarize those and look at them as the average of each of those 3 groups. And you can see what a wide range of experiences. That red line is extremely interesting. It contains a picture of the alcohol controls in mid-1980s, which resulted in a drop in mortality during the time that Gorbachev was putting in stringent controls on access to alcohol. Immediately, you can see the drop in mortality that happened. Also, you can see the rapid rise in mortality in so many of those countries that marked the change to a market economy after the Soviet Union dispersed into its individual independent states. The change to a market economy, the loss of jobs, the insecurity that resulted. Anyway, we could tell many stories about what has happened. But if I focus instead on the last 10 to 15 years, this is what we see. This is the beauty which is not known to many, and that in almost all countries of Europe, you see how we extract some meaning out of the spaghetti. Almost all countries of Europe, we are seeing a decline in mortality. And indeed, the higher mortality countries are declining the fastest. Not only are we seeing a decline, but we're also seeing a convergence. Europe is coming together towards the goal of a decline in premature mortality reduction. A decline in premature mortality. But here's the question. I introduced this concept of a decade already. And we have 1 decade of action. So if we were to do a thought experiment, how long, look at that graph, tell yourself, how long would it take for the red line to reach the blue line, for it to go and become, for the countries that are the highest burden, can they do it in 10 years? Let us imagine that these 3 lines are the natural history of circulatory diseases. And let us do a thought experiment and say, how far back should we displace the lines in order for them to become a continuous curve? And you can see that we have longer, much longer than 10 years to achieve the targets that we are aiming for. We need to go 55 years in the high mortality countries. We need to go as much as 30 years in the middle mortality countries. Imagine what it is like for the low income countries or the low middle income countries of the world. This is, of course, just a thought experiment. No one is saying we're going to follow these. But can you see why I say we need leapfrogging? We cannot wait until the natural progression happens. And this is even more important because today we know things that we did not know 30 or 40 years ago. When I started public health, when I did my master's a bit more than 30 years ago, I remember going onto planes and asking, please, non-smoking as far away from smoking as possible, because at the back there were smoking people and I didn't want to be the last non-smoking row because you got to inhale all the cigarettes. This is, in many countries, you no longer see billboards or advertising on newspapers. You see price increases, you see pictorial health warnings. So the evidence of today needs to be applied in all countries to the problems that we had in the 70s and the 80s. So that is one way in which we leapfrog. There is no need for countries to have to go again through the zombie arguments of the tobacco industry as they try to again bring up issues. If it's legal to sell, it's legal to advertise. I'm trying to avoid bad words in this because we are a webcast. This is silly. Let us call it silly. There's no need for countries to have to make all those mistakes, to go through all those delays and dilutions that the industry puts against us. But today, I am not going to focus on best buys but I have to say that this is extremely important and must be the foundation. Everything else I'm going to talk about today is experimental or research or academic. But the fundamental way in which we do leapfrogging is to focus on the best buys. We know what works, what is cost effective, and what is cost effective for looking around the room for Afghanistan, Bangladesh, Tanzania, as well as Japan, Norway, or Germany. So we have to look at the best buys as our fundamental key to achieving accelerated mortality decline. But today, I was invited to speak about big data. And to put it in the reach, I'm not going to give you a detailed academic presentation on big data. There might be people more qualified to do that. But I am one who dabbles in the field, who's very interested, and I see it as a possible disruption. I would make immediately a statement that those who leave the Masters in Public Health course without having at least tried one of the experiments that I'm going to show you in this presentation should really not go into the Masters of Public Health course in the first place. Because I do think that the next generation of public health people need at least to try and reject the potentials of big data. I'm not suggesting we must use it, nor that it is going to be the solution for everything, but we must try it. Others are trying it. And in the commercial world, big data is now such a byword that they've moved on. They're talking about other big movements. Big data is now no longer an innovation, it's your everyday. So we need to be aware of it in public health. What is big data? You have instinctively an idea. I put up here 4 characteristics that people talk about it. One, it's of course big is large data sets. We're talking here about millions, and we're talking here millions of records. Often big data streams at you. Imagine all the data coming through the Twitter servers, millions of tweets every minute passing through their servers constantly, continuously. Think even in an organization, a big organization, making sales decisions, or in a healthcare organization providing services. Constantly, there is this stream of data about services being provided. The data is often passively collected. In the old days, we used to wear bracelets or pedometers to keep our step count. Today, whether I know it or not, my iPhone is measuring my steps, or my Android. I don't want to stick to one or other. My phone is measuring my steps automatically. There are sensors around us that are passively collecting large amounts of data. And certainly our interaction with the web, etc., is being recorded by someone's servers and being used for commercial reasons. The data is often dirty. Unlike the data that we have in our splendidly managed and curated surveys in epidemiology, in big data, we get much clumsier data coming in. Electronic medical records, where hypertension might be written as hypertension. Another place it might be HTN. In another place it might be high blood pressure. So we're not talking about standardized curated systems. We're talking about volumes of data that are often imprecisely recorded. And we often use big data not to do the descriptive or analytic work that we tend to use with our survey data, but we tend to use it more for predictive analytics and for possibly trying to understand what is going to happen to a group of the population in the future. I realize I've now in 20 minutes into my presentation, and I am about 10 slides into it so I'll speed up a bit. So let's talk about how we could use them. We have 2 weeks ago, we just published this comment in the Lancet, and it underpins some of the thinking. It's about using big data for non-communicable disease surveillance. And surveillance is a good enough place to start. In the olden times, we had much more basic ways of surveilling non-communicable diseases. Yes, some countries notionally have no surveillance system. But for most countries, there is routine data, mortality data, utilization statistics, cancer registers that are used to collect information about non-communicable disease. Beyond that, some countries start to use cross-sectional surveys or continuous interviewing. So every 5 years, a national NCD risk factor survey. In between those 5 years, computer-assisted telephone interviewing, for example. So you get small, tiny samples every day between the two big 5-year points, this way giving you a method of surveilling non-communicable diseases. Both have their advantages, both have their disadvantages. Both together represent a more comprehensive way of doing surveillance. But anyway, more recently, some people, and I'll show you one example, one case study, have started to use electronic medical records as a means of either doing surveillance or augmenting surveillance. And in the paper, we describe 2 types of digital trails, the digital traces that we leave behind. One is the virtual trace of what we say or search for on Twitter or Google or Facebook posts or Instagram or whatever is the social media platform of the day. And the real digital trails, which record things that we have done in real life, like, for example, our transport system, recording our movements, or credit cards, recording our purchases, food purchases, discount cards in supermarkets, or loyalty cards. So these represent sources of data. In the normal, non-leapfrogging way of looking at it, it's a progression. You develop this, then you develop that, then you develop the other, and so on. But if I go, as I have done in August, to Kazakhstan, for example, they have electronic medical records. They have a vast array of electronic data, from social welfare to employment to all the processes of government. But we are together about to organize for the first time a national survey on risk factors for non-communicable diseases. So it is not, leapfrogging in this case is not something we are imagining. It is something that is already happening in countries. And as countries go into mobile phones before they go into toilets, in some countries, you have a sense of how dramatic that, I mean, before they get mobile phones before they get toilets. Everyone goes into toilets at some point, and that's a bad joke. But anyway, the idea is of inverting and how could we use this inversion? So let's take one example. This is something you could do now on your smartphone if you wanted it, or on your computer if it's open. So I don't know how many of you have looked at Google Trends. Do you know what? Can I get a show of hands? How many have even visited Google Trends? Okay, 1, 2, 3, 5. I think it's worth then it's an old facility. It's an old site that Google offers to its marketers and researchers, but it's news, so it's worth looking at. So in Google Trends, you can go to this website, and you can have a look at what are people searching for on Google for a given period of time, for a given region or country, depending on the penetration of Google. And so I did this as a demonstration, looking for how people searched over time for the words quit smoking. And this is the type of screen that you get: a trend line, a graph of where those trends were strongest in the graph, in the map on the side, and the bar chart. You get a picture of the countries and the level of penetration of that search. If you explore it, an example that would not be so impressive in Europe, but is likely to come with some questions and some novelty for us here in Japan, is if I searched for quit smoking in the UK. It would be nice to ask you to do a mental thought, a mental sketch of what that line might look like over time. Indeed, it looks almost like an electrocardiograph. So, with a beat, a peak. Do you know when that peak happens? You can see it's highlighted with the red dots. There's a big peak every January as people make their resolutions to stop smoking, and they look for ways in which to do it. So Google registers this. It knows what they are doing. What you may not immediately notice, but will once I put up the green dots, is that there is a small peak every October. So what happens? Do the British have an October resolution as well on tobacco? If you live in the UK, it's not such a great surprise because they run the Stoptober campaign, which is a month dedicated to stopping smoking in the UK. If you are in the UK, this graph shows you nothing new. But if you are researching tobacco smoking behaviors in Europe, this is one of the interesting patterns that you would find. And beyond that, if you look deeper in Google Trends, you will see what are the related subjects that people look for. So in the UK, they're looking for not just quitting smoking, but they also enter the words in related searches: alcoholic drink, names of medications, acupuncture and alternative therapies. In Spain, the patterns are similar, but electronic cigarette, at least in the time when I did this slide, which is about a month ago, they were also interested in electronic cigarettes and cannabis smoking. So you can see the patterns vary between country. And if you are in a country where there are a high pattern of Google searches, you can even drill down and see inside your country what is the pattern. You might ask, what does it look like in Japan? And I thought, at least this I think is stop smoking, not quit smoking. You do have a pattern here, but I don't know enough to explain it. So it might be interesting for people to play with this. And indeed, the related searches, I can't read them, but there you are. I am told that nothing offensive is on the slide, so at least I can show it. And there is, therefore, already a little insight that you get by just looking lightly at this. And already, whether you like it or not, or whether you know it, you're dealing with big data already. It's not your big data, it's someone else's big data, but there are ways of you're in effect doing what every other example I'm going to show you is doing. You're taking someone's big data set and mining it for some pattern that has public health significance. All of them were interested in e-cigarettes in the examples that I've given you. And so I'm going to take you a bit into a deeper example. This one is an experiment that I have done myself. Excuse me. An experiment that I have done myself on Twitter conversations on e-cigarettes. So you are familiar with the concept of hashtag, and I'm looking for 4 hashtags on e-cigarettes. This is a Twitter page. Nothing to say that. You've seen it all before on your browsers. And it might be interesting in this little experiment to ask ourselves, how do people discuss e-cigarettes? We know that they are looking for it as a means of quitting smoking, but what is the content of their conversation? And for countries that use Twitter a lot, it might be interesting to explore Twitter. So I thought, let's do a bit of this exploration. In order to understand, you know what a tweet looks like. Today, tweets are longer, but the time that I did this experiment was in February of 2015. Tweets were limited then to 140 characters. They've now practically grown for everyone to 280 characters. But it's a short string of text with a picture and a date, basically. Underneath, if you dig into the computer representation of a tweet, this is what it looks like. There's a mass of data that is transmitted between computers that describes everything from when it was tweeted out, how many friends that person has, who are the friends, who has mentioned whom, who has retweeted whom, if they are geolocating, what was latitude and longitude, where were they standing, what is the language. There's a lot of information that does not appear in the small tweet that you see that is available for you. So one Saturday night, I collected, isn't that what you do on a Saturday night? I collected about 30,000 tweets using those four hashtags: e-cigs, e-cigarettes, vapors, and vaping. So basically, I asked Twitter, give me all the tweets, any tweet that contain any or all of these hashtags. And for that period, it gave me 29,284 tweets. This is not big data, but Twitter itself is big data, and I'm doing the mining. I'm digging a bit into it for meaning, extracting these hashtags. If you did this today, you would get a different result because it's changing, it's streaming. This is the concept of big data, basically. We're using this for hypothesis generation. And then I plotted how many tweets were coming out every hour with any of those 4 hashtags. And this is the pattern. Well, if you see a pattern, you're better than me. There's no pattern that I can see. It's a very low conversation that's happening constantly. It never goes down to 0. It's worldwide, about 500 tweets an hour. And that's practically it for the 2 weeks that I had collected the data for. But then, by accident, because I wasn't actually looking for it, I just happened to be doing it, I discovered an earthquake. What do you call this? Suddenly, the next day, on February 19th, 2015, there was an explosion of conversations on these 4 hashtags. So it went from being low-level, negligible conversation to being huge, 2 spikes, followed by a series of aftershocks. It's almost like a Twitter storm or an earthquake with aftershocks had happened. So, of course, I got interested. I zoomed in on those two peaks. Instead of plotting them by hour, I plotted them by minute. I colored them by the other hashtags that were appearing. And you can see that those two peaks were not just big, but they also were health-related. In the previous conversation, health was also almost absent. It was more about prices, availability, new models, etc. But suddenly, these two peaks were all about life-saving and health, which became intriguing, because now you ask yourself, what happened on this day? So this is often where big data takes us, because I could have gone in and looked into the actual content, but I decided to take a shortcut, which is I looked in Google for e-cigarettes February 19th, 2015, and came up with this. This document is the sheet that describes an initiative being taken by the European Union to consider taxing e-cigarettes as a tobacco product. So immediately, you could see the blogs starting. There was a big response. This is a blog of an activist that features e-cigarettes is extremely critical in this case of the European Union and its wish to tax this lifesaver, also quite critical quite often of WHO and its opinions on e-cigarettes. And note, I am not making a note for or against at this stage on e-cigarettes. I'm just saying, let's explore. Which then led me to say, okay, who was involved? It's, you want to know, since this is health, and since I know that we have the opponents, who are the opponents to this measure? Or who was mentioning whom? And I was looking at the field where people mention each other. Who gets mentioned? And this is the table of the people who were mentioned in that conversation. And you can see a very interesting pattern, which I don't have time because I am looking at my timer and it's only 24 minutes left. I don't have time to go into the details here, but I will focus on, this is 2015, remember, this is early 2015. And so there are two names that I highlight here. I don't know whether they mean anything to people in this audience, but certainly they mean a lot to people in Europe and to people in tobacco control. If I zoom in on those two names, Nigel Farage happens to be one of the leaders of the Brexit campaign. That is one of the leaders of the Leave campaign where eventually the referendum over a year and a half later, a referendum that resulted in the vote for Britain to leave the European Union. But the man turns out to be one who comments quite freely on other subjects, such as obesity, and ridiculing any measure to control smoking with smoke-free public places, for example, saying you might as well ban donuts and chip shops. So here is a voice that is linking a big political strategy with also an attitude that is very anti-health promotion in at least the description that I'm presenting here. And Derek Yak was at the time not active in the field of tobacco very much. He was mostly concerned in a recent career with supporting soda in bringing them closer to a health agenda, and then to alcohol and harm reduction and the smart drinking goals of another company. But since then, Derek has become the CEO of a foundation set up by Philip Morris with $1 billion devoted to doing research on a smoke-free world, which is basically a harm reduction effort in the area of tobacco. And I won't say any more, but give you a link to the WHO statement on that foundation, which is basically a front for the tobacco industry as we see it. So one evening's just fortuitous glance at the big patterns of data that lie inside Twitter allowed a number of insights retrospectively on the work and the motives of certain people, and identified people with interests in the area of tobacco and health in ways that you might argue are not groundbreakingly new. But I would argue that if every policymaker could open a window in the morning and look at key hashtags at a portal, looking at what the conversation is like in their country and who is participating in that conversation, that policymaker would be gaining information. And here's a PhD idea. Here is someone who could say, okay, what would this mean of practical use? What value would it add to a policymaker who had access to this sort of political information, not 2 years after it happened, but on the day that it was taking place? I've spoken about electronic medical records, and I'll give you a case study from Israel and a slide from Hungary to sort of round it off with that last box in the progression of green boxes that I showed you earlier. Electronic medical record. A bit of background. The future 4 or 5 slides are by my colleague Ran Baliser, who is the head of the Clalit Research Institute, where this case study is based. So it's a sick fund in Israel. It covers 4 million people. It has a high representation of low socioeconomic population of Israel, minorities and the elderly. So it's not a select population or a high-income population. It's the needier population. And they have an information system, which is basically an in-house big data system, where they collect data of all those dimensions and coordinate it. The data covers decades of a lifespan. So it is a whole life course. It's a person's complete access to all the health services, whether it's local or whether it's community-based, whether it's hospital. More recently, they have added mental health. So it is across settings, wherever in the country, whichever provider the person is coming into, as long as they're with the same sick fund, that information gets coordinated. It's coded by geography. It's identified by a unique identifier. And it is, as I said, data on more than 4 million people. So this is a resource that in Europe is beginning to become available, not just in a high-income country such as this one, but we're beginning to see it in the middle-income countries. And I would predict it's going to be available in at least even low-income countries, at least in the private facilities, if not more generally, because the cost of doing this is declining to such a level that it's becoming much more accessible, and independently of what we say, but the business people might be interested in seeing it. So here is us possibly taking advantage of it. So here's some of the patterns that they are able to show. And in order to leave some time for discussion and comments, I will not go into the details of these 4 examples, but this graph shows the proportion of the Clalit population, of their 4 million people, that suffer from 0, 1, 2, or up to 5 of these risk factors: smoking, obesity, hyperglycemia, hyperlipidemia, and hypertension. So if you look at it, here is the pattern. So you know where the population lies that has 0 risk factors, 2 risk factors, 3, or up to 5 risk factors. Of course, as we go further down the life course, we see risk factors accumulating. But also, it allows you immediately, if you are a planner, to say, okay, I'm going to address people with 2 risk factors. Therefore, you know how many are going to be targeted. With 3 risk factors, you know which age groups, where they live. This is coming automatically in real time. You could generally have this every day if it was useful for you, while getting the same information from a survey would probably be much more accurate, would be about the 8 million people of the country, not the 4 million people, but it would happen every 5 years at great expense. So here is a trade-off that can be made, but it's the sort of immediate return on the most accessible form of big data that could happen. This is the same graph, but showing the accumulation of chronic conditions, whether it is asthma or arthritis or diabetes or hypertension, as these conditions accumulate throughout life. It's also interesting to see how after the age of 40, basically, multimorbidity is the problem that health services face. So big data is not depersonalizing people. It is actually saying, here are the multiple conditions, whether it is asthma or chronic renal failure. You need to be looking for all the morbidity and addressing your systems to target those people who have the highest number of risks or the highest number of conditions. And you can even titrate services based on, for example, potential outcome, not just on issues related to budget, what is cheaper, but what is most likely to give you a result. And this is an example of that. This example won the data analysis challenge that was run by the Sprint Data Analysis Challenge run by the New England Journal. And I'm happy for this presentation to be shared, and you can look up that link. It describes this, this facility. Basically, imagine you are sitting on this vast amount of data underneath. On top, you have this interface where you enter the data about your current patient, whether they're a smoker, what age, what sex, what is their race, what is their weight and height, systolic blood pressure. The question you are asking when you press the calculate button is, what are the advantages and disadvantages of giving this person intensive antihypertensive therapy? And the model looks into the data set, these millions of data points that lie below, and gives you a set of estimates of what will improve in green and what is likely to be the negative effects in red, and eventually summarizes that into a risk score with a recommendation. In this case, treat the patient or don't treat. Now, of course, we do this in a simplified fashion when we use things like the Framingham risk score in primary care to identify the risk of the 10-year risk of a cardiovascular event. So we do have low-tech ways of doing the same thing, but this is a provider of health services that is using its own data in real time to calculate and to identify clinical recommendations based on the likely outcome among its population. Deservedly won the top prize in that contest and serves, if not as a generalizable instrument, it serves as an example of what we could do if we apply big data to surveillance of populations, to risk stratification, to helping providers make management decisions. And this is another one-slide example of a network analysis of oncology services. This one is provided by my colleague Miklos Sochka, who was Minister of Health at one point, and is himself a big data aficionado. And he has a lot of examples. And when I asked for some of them, he gave me a long list, and I realized I don't have time to give you much more. But here is an example of a plot of all the cancer facilities in Hungary by county. So you can see it as a rough map, and you can see the movements of patients between these facilities, between these oncology facilities. From this, you can see patterns lightly. For example, on the east, on the right of the graph, it's actually the right of the map, you can see that there is little movement, and that there's lower provision, and there are hospitals, nodes that are mostly providing all the service themselves without exchange. While there's a very dense network in the center in Budapest, where basically everyone is going to every facility depending on what is good. This sort of analysis was used when Miklos was minister to identify which facilities in Budapest, for example, could be closed with least impact on the patients, so that you can save some money, concentrate the services, at the same time cause least inconvenience to the least number of people. So this is exactly the same network analysis methodology that I use to identify the key participants in the conversation in Twitter. So my point is very much that a few set of basic techniques have applications that are as varied from dissecting a policy discussion to deciding which hospitals to close. So these techniques are very powerful, and I believe that public health people should be exposed to their existence at least, if not to be able to use them themselves. So here are my two concluding slides. This summarizes most of what I have said. If we look at the non-communicable disease intersection with big data, we see that in the four main strategic areas of action on non-communicable disease, whether it's governance, surveillance, prevention, or control, there are very interesting, very powerful, potentially disruptive uses of big data that we can apply ourselves to. And indeed, none of the examples that I have given you are conclusive demonstrations of something that a public health physician should be doing every day. But in an academic environment, I would argue that investigating the set of questions summarized in this slide is actually an urgent task for all people involved in public health and its development worldwide, because these techniques are rapidly being used by commercial agencies to great effect and to great advantage. We need to do the same. Knowing that the moment you start looking for anything related to the subjects that I have discussed, you will immediately come up with people who will, and articles that will tell you about the potential shortcomings. Indeed, as I was speaking, I think every single person has said, oh, not this. So that at some point, someone has objected to something that I have said. And hopefully, this hasn't been everyone objecting to everything that I have said, but that you will have thought, but there's this shortcoming. So yes, I am aware there are a lot of shortcomings. Methodologically, the validity of the data, the validity of their predictions. Google at one point was able to predict an influenza epidemic in the United States 2 weeks before CDC recognized it. But at one point that stopped working. And so they no longer make a big case out of it these days. Maybe people change their search patterns. Maybe it needs more research. Maybe their models needed to be further refined. Maybe they have a new model. Right? So there are the reproducibility, the problem of artifacts, the methodology, and I already said the magic word, dirty data, which gets many epidemiologists turned off immediately anyway. So they won't even continue the discussion. So issues there, legal and ethical issues, data protection, data privacy, prohibitions on data linkage. You cannot link my tax data to my social welfare data, to my employment data, to my health data. Some countries allow you to do that. Some countries don't even allow you to look at the phone data if you're a phone company. So it really varies a lot by countries. The issue of intrusion by governments on people's lives, and the problem increasingly being recognized as that as people make predictions, those predictions are likely to reinforce existing prejudices in the data. If you are using, let us say, a predictive algorithm to see, shall I employ this person, give this person a job? And if in the past I have tended to employ men over women, the algorithm will give me a better likelihood for a man than it will tell me for a woman, because it's reinforcing, it's building its model on the data that has been there in the past. So we need to police the algorithms. We need to see how to curate the data sets that are used. These are all legal and ethical issues, but I would suggest that these are also public health concerns. There are commercial issues and shortcomings. Much of the data that's available is proprietary. Twitter, under certain rules, allows you to use their data in vast quantities. Facebook, if you try to do that, you're breaking the rules. You are going against their terms of reference. Misaligned incentives. If you're using electronic medical records and you have a health system where there are certain fees for service, then you're likely to be collecting data on certain incentives of the providers rather than on the needs of the population. So there is a set of issues there that also need to be described and used. And finally, though, as I go around, as you can see, I'm fairly passionate about this tool, and I spend a lot of my time. This is not a formal WHO activity as yet. It's more at a time where I am sharing with you my own explorations and learning, as opposed to any mandate or formal action on the part of my organization. But I find that there are at least 2 generations of public health people behind me, and yet many of these issues are beyond even 2 generations behind me. 2 generations behind me, everyone knows how to use a smartphone, but very few people know even a modicum of programming, or would even know where to find the data that I am looking at. And I am suggesting that maybe there is an opportunity for an academic institution to be looking at this as an exploratory idea, to look at imparting the skills, making new recruits familiar with the tools, and maybe to spark what is the worst element of loss of capacity when people don't have imagination to even ask questions that might be answered. So to spark the imagination, to inspire people to start entering this world, leapfrogging routine data systems with the potentials of this vast new world of big data, machine learning, deep learning, whatever is the field that you decide to go into. To that imagination, thank you for listening. ありがとうございました。
Okay, thank you very much, Gauden, for your fascinating talk. So we have around 15 minutes for questions and comments for him. Does anyone who have a question or comments? Okay. Yeah. Okay, yeah, starting from, in the first row.
Thank you for the great lecture. I'm a student at TMDU. My name is Akane. And I have a question about big data. You said it's kind of ethical issue because it's related to the people's privacy or kinds of such problem. And I wonder if we use the patient's data for big data, maybe we might need them to sign a paper, or we might So if we do that, will that data, well, my question is, can we use that data as a big data, or is there some kinds of bias, I'm afraid? So what do you think about this?
Yeah, so shall we share the question first?
Thank you for the good presentation and good information about big data. My question is about the ethical clearance, as you said, is among the shortcomings of the using of this big data, especially for the online, for example, Facebook or Twitter. But my concern is what happens if the company give you the permission to use the data, for example, Facebook company. But what about the issue of the users, Facebook users? Do you need the informed consent, or what about the issues of the users aspect?
Thank you very much for this great talk. My question is...
Could you introduce yourself?
I'm Amin. I'm from Immunology Lab, TMDU. My question is, if we can do such analyzing with big data, isn't it better to give this job to some professional company, or I don't know, some people like IT people or someone like that? Because I think to analyze or to interpret would be, if it is wrong or do not considering some issues, would be a big misleading also. Thank you.
Point. Does anyone who have a question so far? Okay, that. Okay. Could you turn on the mic?
Sorry. I have two questions. First of all, already she asked you about the ethical value or patient safety. So I know the big data have some problem like ownership or security. But my question is that how can we solve these issues like ownership of data or security reason? And second question is that because it is not like ordinary data, we have to collect data from several sources. So can we apply the same methodology as big data as our ordinary or traditional data?
Yeah. And okay.
I have just one question. In big data, you show the trend of different social characters or some things that people are using or searching in the field. But how we can predict after 10 years in mathematical modeling what will happen? Like in Bayesian statistics, we can pick a model, prediction model. After 10 years or 15 years, what may happen by simulating, we can give some trends. But in big data, how is there any mathematical modeling or technical things that can be applied to predict after 10 years what will happen?
Okay, then probably Daniel-san.
Thank you so much for the presentation. My name is Eriko. I'm the 5th year of medical faculty of medicine. Maybe my question is similar to hers about the any kind of health surveillance at the governmental level. In Japan, the system called My Number system has launched, in which the government assign each of us to assign a personal number to each of us. And I think that system is potential to the big data surveillance by summing up the electronic charts and our health state for insurance systems. And in European countries, maybe the government is now collecting the personal data for the health surveillance, and I think it's really hard to balance the data protection and the surveillance. So I wonder what is the breakthrough for Japanese government to utilize the My Number system for big data.
Mashal-san.
Thank you very much. My name is Mashal. I am 4th year PhD student Team DU. My question is how the policy influence or the implication of the big data for policy is. Is it different from that of traditional surveys or each 5-year surveys we do, or it's different? So if the policy influence and implication is the same, then the need might be explored. Thank you.
Okay, and Oishi-kun.
Thank you for your kind presentation. My name is Akihiro. My question is about the influence of the Brexit to the research using the big data. So it will be related to the some kind of policy, or the economics is very influenced by the Brexit. How about the research in big data?
Okay, maybe, yeah. Aida-sensei.
Thank you very much for your wonderful presentation. I'm Jun Aida from Tohoku University Department of Dentistry. My question is about the health promotion activity in social media. In your speaking, you talked about e-cigarette and Twitter, and people opposed to tobacco regulation had a big power in Twitter. So because the tobacco industry have a lot of motivation for opposed to health promotion activity, how to fight against this kind of activity in social media? What should we do? And that's my question. Thank you.
All right, thank you very much. So could you start?
Okay, I should have left an hour. I am flattered at the interest and the range and how you have engaged with this. So great. Some overlap. So there was a set of questions on privacy, ethical clearance, ownership, and security. So let's start with that batch first. Every time you accept the terms of reference in any of these major free services, you are, read them, don't take my word for it, read it once, especially the concerns about data use and reuse, and you will find that you have signed away all rights for all that data. So anything that you are posting on Facebook is recorded by Facebook. So, I mean, I heard someone claim, I have seen nothing from Facebook itself, but even your deleted characters. I don't know, my boss is an idiot, delete, 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 is out of the office. So publish. So you publish out of the office, but Facebook has recorded that you thought your boss is an idiot and has kept it somewhere inside. Whether they do that or not, all the data that you are giving to Facebook, to Twitter, to Google, this, so if there are ways, they may offer you ways in which you can not share that data. For example, many browsers have incognito mode, or some search engines commit themselves to not keeping your searches. But ownership is already granted, full stop. So you've given it away by accepting to use that free service. And the only way you can control that is by not using the service. I'm not asking you to stop, but I'm asking you to consider this. The issue becomes more complicated when Twitter, for example, or one of these companies accepts to allow you, external researcher, to be able to use that data. And it is quite interesting. I am currently filling in exactly such a form in order to be able to have access to the data. And they are quite responsible about the questions that they ask. For example, are you trying to use this to identify individual users and to analyze their personal behavior? I'm quite sure that if you agree, if you say yes, you will not be granted that access. So that doesn't mean that you should lie, but it means that if you do lie and get access and then do it, then you could face a major humiliation if you try to publish that data. So legitimate researchers will be kept to legitimate uses when that data is shared outside. But then that leads us to the example of Clalit, which is why I gave it 4 or 5 slides, because there people are asked, they are allowed by law to use their own data for their own purposes in order to improve the quality and the efficiency of services inside their organization. And there are many benefits that have emerged. But if an external researcher wanted to go and use them, this would not be allowed. So this is one model. I was asked, how would you use these data ethically? And one of them is, we may not be allowed by law to do linkage, Eriko. We may not be allowed to join the data in social services with tax and with health, where we might learn things that might be even allowing us to identify criminal behavior, which is not what we want. But if we are the health service collecting health data, it should be possible to use that internally for our health applications. And all the Clalit examples were chosen to demonstrate exactly that base. So, of course, PINs, personal identification numbers, do create that problem of possibly other nefarious users might steal the data and do that linkage themselves. So this becomes a technology arms race. So you need to have, if you're going to collect big data, know that there are people who want to steal it, full stop. So there's no doubt about it, that people will try, not once a month, but many times a day, there will be people trying to test the vulnerability. They have automated ways of testing the vulnerability, and you only need to let your guard down once. So you need to adopt certain good practices. For example, separate the identifier from the data itself, so that if they need to hack 2 different computer systems, for example, to get both the person as well as their condition, that way you can minimize the impact of a possible hack. But again, security issues must be dealt with. In many countries, in Europe, we have the full range. We have countries, as I said, that do not even let a phone company look at its own phone data, if not for marketing purposes. So that they can't even use it for their own data for marketing purposes, to having countries where there is absolutely no legislation and where everything is allowed. It is likely that we will all migrate to some sort of happy mean or unhappy, depending on who is creating the compromise, where some middle ground is going to be allowed. I'll tick off ownership, security, ethical clearance, and privacy. I've given you hints. I know I haven't answered specifically. Methods. Can we apply the same statistical techniques? And can we predict after 10 years? Can we, what impact do they have on policy implications? So I think you can see that none of the slides that I presented have some major new statistics behind them. Indeed, even when they put together names like machine learning and deep learning and so on, underneath there are some very basic old statistical techniques applied in new ways. And so the level, there's a lot of innovation going on into how they are used. And when you put them in conjunction, those statistical techniques to artificial intelligence, where computers can mimic through neural networks the behavior of the human brain and synapses, and learn and adjust their estimates repeatedly, iteratively over time, we've reached a stage with AlphaGo 0, for example, where a computer is able to learn how to play Go at grandmaster level without ever having played against anyone else, just playing against itself over a few hours, just knowing the rules. It's incredible, with no basic data fed into it. So the applications are going to grow, but underneath, anyone who has done a statistics course can understand the basics. And indeed, if you go to the online offerings, there are some very good online courses on machine learning with a little statistics. You can be versed in at least basic techniques. And there is at least one site, Kaggle, that teaches you these techniques by, and I use no machine learning in any of this myself. The models that I have given you did use them, but in my own first two examples, I just wanted to give you an easy entry point. So I think that covers predicting after 10 years. The answer is yes, if the basic data has it. So the basic, there's a big debate, as we know, on using things like the Framingham risk score, because we're using a tool that's developed for population level use at the level of the individual. And there are issues about that, but I won't go into them. That's a different debate. What we have here is, if you have outcome data that's 5 years old in your health facility, then you can, to some level of confidence, predict 5-year outcomes. If you've collected lifetime data, you can try to predict lifetime outcomes. So the predictive reach is based more not by the techniques, but by the input data that you give. How different is the policy implication? I was trying to look at the person who, to find who answered. Interestingly, when you go to Amazon and you order a book, it tells you what other books you are likely to be interested in. It makes a prediction based on, so this is a common example that people use. In Clalit, they use the same techniques, for example, to predict what is the likelihood that an elderly patient being discharged from hospital is going to get readmitted in 3 months, in 1 month's time. So there is a risk score that says high risk of readmission in 1 month's time, low risk of readmission in 1 month's time. I think it's a 7-point, and 7 is the highest risk of readmission in 1 month's time. Obviously, when you discharge a person, you want them to stay healthy and well in the community. So that score is used to identify the patients in need of a home visit in order to stop them ideally from coming back. So a high risk score gets associated with a scheduled visit at the home in 2 weeks' time. Now that's a very interesting way. This predictive approach would not have been possible with the normal techniques that we use. So I like to think that our normal techniques are more about description, how many elderly patients are readmitted within a month, analysis, socioeconomic group, rural or urban or whatever, age, gender, you get a good picture of who gets readmitted, classification by disease, but the predictive element is coming in ways that did not exist, or at least has not been used with our traditional techniques in that way. Which leaves me with 3 questions. Should we give it to the IT people? Absolutely yes. I would suggest that the techniques of handling big data are not the techniques of public health people. That you're going to make big mistakes and put people's information at risk if you try and dabble in it as an amateur. So absolutely, all this work should be done in close cooperation with knowledgeable IT people, not just IT people at large. They need to know the subject because not every person is aware of info security, for example. So yes, but at the same time, I think that the use of this data needs the public health imagination. So what I would see is a team. People need to come together and agree on ways of working. It's not just the collection, the streaming, the security, the protection of the data. That's IT. System operators need to take care of that, and system administrators. But certainly, the use of the data requires public health imagination. Health promotion activity in social media, I think very much untapped. What I see in health promotion up to now is people using social media to broadcast their events. Something as simple as giving your event a unique name, like Stoptober in the example, gives you a hashtag that you can then do Google search trends on, just to give you one example. So it ranges from minor changes to make your program identifiable in searches. Therefore, you can look at search trends. And it's useless using an acronym that someone else has used already, for example, because then, or an acronym that's a word that's already in use, because then Google will not help you. So to be able to use the data in simple ways like that, to more sophisticated ways, who are the people participating in anti-vaccination discussions? What is the sentiment, positive or negative, at that discussion? what are the points that they are saying that we can address in our publications or our publicity campaigns. So there's a lot to do in health promotion that goes beyond sending people texts to remind them to take their blood pressure pills or sort of using Twitter or other social media as just a broadcast medium. There's more to be done, as yet still largely not unexplored. You will find many papers of this nature, but not yet mainstream. I think we need to mainstream them more. If I understood well, the last question, does Brexit have an impact on the ability to run big data? We, at this point, can't comment on what the final what will happen with Brexit finally, but if one country left the European Union, which is not the European region, it would not have an impact on the policies of the EU at large, and it might or might not have an impact on the country. So at this stage, it's impossible to say, but these points that I am making are largely independent of any individual country. They are something that each country will need to explore for itself, understanding, though, that information about its citizens might be stored in another country, on a cloud server in another country, and there might be different rules that apply. So that might lead to different national jurisdictions on data ownership and storage, etc. So you are right in asking the question. I don't know how to answer it. I'm sure no one knows how to answer it in the case of Brexit at this stage. I think that in one way or another, I have touched on every question. So another thank you for the chance to be here and for your enthusiasm. Thank you.
Okay, so it's about time. So let's close this commemorating session to opening Master of Public Health at TMDU. So please give him a biggest applause again. Thank you very much, Gauden.では以上で終わりになります。ありがとうございました。でちょっとインタビューのコメントをお願いしている方は、どちらに行けばいいかな、前の方にお越しください。